we go. Okay. So Great Ormond Street is a tertiary level service, which means that we get patients referred to us from hospitals around the UK and also some who come from abroad. In terms of speech therapy, we work in different teams, and I'm a member of the dysphagia team, and dysphagia is basically any difficulty to do with eating, drinking, swallowing. We're really lucky in that we've just had some new funding for a post with special responsibility for children with lysosomal storage disorders, and I was appointed to this post a few months ago. So I'm quite new into the post, but it's quite an exciting time for us because it means that we can now offer a specific therapist for children coming in to clinic or as inpatients, and hopefully also start to develop a few more sort of protocols and expand our knowledge and expertise in this area. So the basics of eating and drinking. These are just some generic pictures from the internet. The reason we're concerned about eating and drinking is really three main factors. We talk about safety. So we need to make sure that what we eat and drink goes down the right way, that it's safe for us to eat and drink, and that it doesn't do us any harm. And I'll elaborate on that a little bit later. Adequacy, we need to make sure that we're eating enough and drinking enough of the right kind of nutrition to make sure that we meet our nutritional and hydration needs. And then the last factor, which isn't by any means the least important, is the social and enjoyment factor. Feeding is an important bonding experience for infants and children, and also in older children and adults. It forms a focus of many social groups across cultures, big families, friends, etc. We get together to eat and drink together, so that's an important social aspect. So I'm just going to explain the mechanics of eating and drinking, because it's something that we do without really thinking about sort of how or why we do it. Let me see if this, how do I? So up here is a diagrammatic representation of the head and neck in infants, and this bottom one here is of an older child or adult. So just briefly, here would be the nose, here is the mouth, tongue, and then this here is the entrance to the airway with the vocal cords here, and here is the entrance to the esophagus, and you can see that again in the adult down the bottom. There's some important differences between the anatomy of an infant and an adult, in that you can see here in the infant, the tongue really fills the mouth much more than it does in the adult. And the epiglottis, which is here, which I'll talk a little bit more about in a minute, and the soft palate in the infants are pretty much approximated, which is one of the factors which makes it possible for infants to feed in a more horizontal position, whereas here in the adult you can see you've got a big gap here. And also in the adult, the larynx, which is this bit here, is much lower in relation to the other structures than it is in an infant. So it's generally accepted in the literature that infants feed in a one-to-one-to-one pattern of sucking, swallowing, and breathing. So one suck, then a swallow, then a breath. And that coordination is really important, and infants need to be able to master that to be able to feed effectively. And that's really obviously important for our infants with Pompe disease, because, as we've heard, respiration is often a significant difficulty for them, and that can then impact on that coordination and on their feeding. In adults, the phases of swallowing are generally divided into three, or sometimes we talk about four phases. Talk about the oral phase, which is from when the food first goes into the mouth, being able to open your mouth to take it in, lip seal, tongue movement, ability to chew the food effectively, and then the ability to form what we call a bolus, so the little ball of food, and move it towards the back of your mouth. Once it reaches the back of your mouth, more or less around here, you trigger the pharyngeal phase. The oral phase is entirely voluntary, whereas the pharyngeal phase is much more involuntary. And the most crucial factor in this is airway protection. Because as you can see, we've got our airway open here, and we want all the food and drink to go here, into the esophagus. So what happens when we when we trigger the pharyngeal phase is that in adults we trigger movement of the larynx here. So this moves upwards and forwards, and this epiglottis here tips backwards so that it covers the airway so that the food and drink can then enter the esophagus safely. Once it enters the esophagus, it enters the esophageal phase, surprisingly enough, and that's completely involuntary, and that's basically muscle relaxation and contraction, which we call peristalsis, which moves the food and drink down into the stomach. This is really a completely separate phase, and it's not something I'm going to talk about today. So why do we assess it? I mentioned safety earlier, and aspiration has also been mentioned in a couple of the talks already today. Aspiration is basically when food or liquid enters this airway here. Oh, there we go. Instead of going into the esophagus. And it's aspiration if it comes into the airway and goes below the level of the vocal cords. If it goes in and then is coughed out, then we call it airway penetration. It's just a technical difference, really. The consequences of aspiration can be, you may see choking, but also in the medium term, we see much more the consequences of chest infection, and that may be recurrent chest infections over time. And there is also some evidence to show that in the much longer term, if you have chronic aspiration, so lots of milk, for example, going into the lungs, there can be some long-term changes to the structure of the lung surface. And as we said earlier, a chest infection can be a very serious consequence for a child. Aspiration can occur for a number of reasons. In an infant, for example, it can occur if that coordination between breathing and swallowing isn't quite right. So they're not quite managing to close this airway in time for the milk to be swallowed and then reopen it when all the milk has gone down. Because if they're trying to breathe very fast, for example, they're almost trying to open their airway before the swallow has completed. It can also happen related to muscle weakness. So if we, for example, in an adult or an older child, have weakness of muscles that move the larynx, then the airway isn't able to move out of the way well enough, then that can also result in aspiration. So that's the safety aspect. We also assess, together with our dietetic colleagues, to look at adequacy, to make sure that the type of food that children are eating is the right type of food so that they can maintain their nutritional needs. And then again, because of the enjoyment factors, we're also looking to see what difficulties the child is having and is there anything that we can do to help with that. So what difficulties might you notice? These are some of the things that parents or carers might notice that might flag up a difficulty with eating or drinking. So difficulty chewing, coughing at meal times, refusing food sometimes if children are finding it difficult and they find the easiest way is just to refuse it. Fatigue over time, so maybe managing well at the beginning of a meal and not so well later on. Over a longer period, weight loss or gagging on certain consistencies, particularly in younger children or infants. So in terms of assessment, some of our children are referred to us on the wards if they're inpatients for investigations or treatments, or quite often they're also referred to us if they come for a clinic appointment, for example, and parents and carers are reporting difficulties with eating and drinking, then the consultant might ask us to then have an appointment with the child. The first thing we would do is to get a history from a parent. So what difficulties are they having? Have they noticed anything that seems to help with those difficulties? What's their weight gain like? What food and drink do they eat? So are there particular consistencies that they manage? For example, they only eat puree food or they can't manage hard lumps. So we build up a picture of the child's general pattern of eating and drinking.